Okay, the topic that we'll discuss today is the metabolic response to injury. However, before we proceed with that, I do want to review last week's topic, since some of the concepts that we discussed last week are going to be important for today's topic. An injured patient mounts a hormonal response. And there's really three major effects of this response. There's a hyperglycemic response, which primarily keeps glucose levels high because the CNS and a few other tissues are obligate glucose users in the immediate injury period. Hyperglycemia also has a secondary effect on increasing circulating volume through an osmotic effect as well. The hyperglycemic response is primarily under the influence of cortisol, although glucagon and epinephrine and growth hormone also contribute to this. Another major effect is the cardiovascular effect, and this is primarily under the influence of epinephrine and the sympathetic nervous system. Under the influence of epinephrine, blood pressure increases to maintain critical organ perfusion, and heart rate, stroke volume, and conductivity improve. All this leads to improved cardiac output. The last major hormonal response to injury results in increased circulating plasma volume. This is under the influence of antidiuretic hormone, which causes water absorption in the distal kidney, and aldosterone, which results in salt and water absorption in the distal kidney. There is also an inflammatory response to injury. And interestingly, the inflammatory response in an injured patient is exactly the same response as if a pathogen was present. The immune system recognizes danger, and that could be an extrinsic threat like a bacteria or an intrinsic threat like damaged tissue. The end result in all of these cases is a cytokine release and the beginnings of the cytokine cascade. Cytokines mediate coagulation and wound healing and are critically important in a patient recovering from their injury. But too much cytokine release or too prolonged a cytokine release ultimately can cause a sustained inflammatory reaction, which overall can be bad for the organism. All right. I do want to talk about the metabolic response to injury, but before we get there, we're going to talk about fasting first. This is a simpler situation, and I think it's instructive to go over that and then make some contrasts with an injured patient. First of all, we need about 2,000 calories a day. It's a pretty good ballpark number. It doesn't fit every case, of course, but in general, you're not going to be too far off if you estimate 2,000 kcals a day. Now, when you're injured or when you're fasting, our body needs glucose. Neurons and white cells are obligate glucose users. In fact, they need about 180 grams over 24 hours. So where is this glucose going to come from? Well, we have a store in our liver in the form of glycogen, but we only have about 16 hours of supply here. So it's not really very much. And so after we tap into this sort of glucose rainy day fund and use it up, if the fast continues, then we need to find other sources to make glucose. And those other sources are going to be body fat, in particular the glycerol backbone of triglycerides, and muscle protein. Okay, so let's say you decided to go on a short fast of a couple of days. It was just critically important to you that you lost a couple of pounds. And so you decide you'll eat dinner Friday night and you won't eat dinner, you won't eat again until Monday morning. So what's going to happen during this time period? Well, your glucose levels are going to fall, and that's going to result in a decrease in insulin. However, the counter-regulatory hormones, glucagon, epinephrine, and cortisol, will rise. They sense the decreased glucose, and they're mobilized into action to begin the gluconeogenic process. Gluconeogenesis can use several different precursors. Lactate comes from skeletal muscle and is important in this process. It's called the Cori cycle in the liver. The glycerol backbone from triglycerides is important. And then amino acids, particularly alanine and glutamine, are used as well if necessary. And it usually is necessary to use amino acids because the amount of lactate and glycerol available is usually not sufficient to maintain glucose homeostasis in the early injury period. And so the shortfall must be made up by breaking down protein into amino acids. The protein breakdown, again, is under the influence of cortisol primarily, and also the decreased insulin around is important as well. Now, as time goes on, and if the fast progressed, you're able to decrease the amount of protein breakdown. So you can go from 75 grams a day to maybe 15 to 20 grams a day, which is useful, but it never goes to zero. The primary reason for this decrease is that the CNS and other obligate glucose-using tissues can switch over to using ketones. Lipids also are an incredibly important source of calories during a fast. We're able to mobilize triglycerides to get fatty acids and glycerol. Free fatty acids are used by a number of tissues as a primary energy source, including the heart and skeletal muscle. The kidney and liver is also able to use them as well. And as the fast progresses, free fatty acids become converted into ketone bodies as more and more tissues are able to switch over to the use of ketones. Well, let's say you decided to increase your fast. You were so thrilled with the results of your 2-day fast, you decide to carry it on for another week. So what's going to happen here? Well, the first thing that happens is the body's able to downregulate its basal metabolic rate, and it's able to drop it from that 2,000 calories a day to about 1,500 a day. This is because sympathetic nervous system activity is decreased, and also skeletal muscle activity is decreased. A patient who's fasting for a couple of days or more has very little energy, and they're really not going to want to get off the couch at all. So they watch a lot of Netflix and TV and don't do much else. As this fast progresses, again, the amount of muscle protein that's diverted to glucose is decreased, but again, never hit zero. The brain is now using ketones, and in fact, ketones are able to provide about 70% of the body's energy requirements. So this picture sums it up pretty nicely. The glycogen is purple, and you can see after 24 hours, it's gone, and it doesn't get regenerated during this fast. So it's a one-time use sort of thing. Fats ramp up very quickly, and ketones will always be important during the fast. They become the predominant energy source. Gluconeogenesis peaks at about 2 days, and then drifts downwards, but it never gets to zero at all. Because under the influence of cortisol and some other hormones, protein is being catabolized. All right. So that's what happens in fasting. That's a relatively straightforward case. Let's see what goes on in an injured patient, which is more our concern, of course. First of all, there's a huge difference between fasting and injury. And in general, when you're starving or fasting, the body's able to conserve energy and protein. A fasting patient is able to decrease their metabolic rate by a fair amount. However, during injury, because of the hormonal environment, there's an obligate increase in energy expenditure and nitrogen excretion. Nitrogen excretion is just a fancy way of saying that there's protein catabolism going on, and that protein is being diverted to glucose. And so the injured patient is unable to downregulate their basal metabolic rate. In fact, that rate increases. And so that can get us into trouble very quickly because the body's energy stores and protein stores can be catabolized very quickly. Another problem in the post-injury environment is that the body is unable to use ketones efficiently. In fact, the more injured you are, the greater the severity of the injury, the less efficient is your production and utilization of ketones. So that puts increased pressure on protein catabolism to provide glucose. And of course, this cannot go on forever. Protein is designed to do useful things. And if protein is being diverted to make glucose, then there aren't enough precursors to do the useful activity that's required. In 1930, a British surgeon named Cutherson sort of described the ebb and flow phases of injury, and this is still a useful construct. Dr. Moore, who was a US surgeon, added to this diagram the recovery part of it. And the timeline down there shows us how this can progress and how these ebb and flow phases are associated with shock and then catabolism, and then ultimately anabolism as the body regenerates itself. So the ebb phase lasts 24 hours or less. This is a period of hemodynamic instability and shock. And it's at this point where the patient is either going to be resuscitated or not. If the patient's not resuscitated, then they're going to die of their injuries. As this resuscitation effort goes on, there is a decreased energy expenditure and oxygen consumption associated with this phase. However, if the patient survives the resuscitative phase, then they enter this so-called flow phase. And this is under the influence of the sympathetic nervous system and many of the hormones that we've talked about. So we now go from a decreased metabolic rate to a greatly increased metabolic rate, and oxygen consumption goes up as well. Injured patients usually develop a fever 24 to 48 hours into the injury. This is under the influence of cytokines and the inflammatory response. The body needs to make glucose for the obligate glucose-using tissues. Blood volume continues to be restored under the influence of ADH and aldosterone. And then the inflammatory response kicks in the production of acute phase reactants, various immunoreactive proteins, coagulation factors, all the stuff that's ultimately going to be necessary to begin the wound healing process. So this flow phase is really a phase of increased metabolic rate. And ultimately, an increased metabolic rate means that we have an increased energy expenditure. In fact, the more seriously you're injured, the more your energy expenditure increases. Energy expenditure, or basal metabolic rate, is under the activity of the sympathetic nervous system. Cortisol, although hugely important for the hyperglycemic response, does not have an effect on energy expenditure or basal metabolic rate. Ultimately, if the patient gets through this flow phase, they're going to enter the early anabolic phase. And what gets you from this flow phase, where you're very catabolic, into the anabolic phase? Well, ultimately, this is going to happen when the injuries are sufficiently healed. After an elective operation, like a colectomy, anabolism begins relatively shortly after the surgery. In a septic patient, it could be several weeks or more. And in a burn patient, it might be months before they enter this anabolic phase. But ultimately, this phase happens when the injuries are healed. The influence of this is the hormones of injury come back down to normal. So cortisol heads back to normal. Epinephrine heads back to normal. In our elective patients, you will notice this when you're making rounds. By day 3 or so, many of our patients have started to diurese. We gave them a fair amount of fluids for the first day or two to support their urine output. And then as these hormones come back down to their baseline level, all of a sudden, all that fluid we gave them now is given back and the urine output becomes very brisk. For the first day or two of injury, patients usually are not terribly interested in drinking or eating. But once they start asking for something to drink or something to eat, that's always a good sign that our patient is now entering sort of this anabolic wound healing type phase. During this phase, nitrogen balance is now positive, which just means that we're in a net synthesis phase. Unfortunately, gaining back the protein you lost is much slower than the rate of initial loss. And as anabolism progresses, fat is the last thing to be restored. Nitrogen balance ultimately will head back to baseline. The patient will get back to their sort of pre-surgery or pre-injury weight. It seems like our body has a set point, and ultimately we get back to this point. But that weight gain can take quite a long time. All right, we'll talk about a few of the metabolites that are relevant in injury. I suspect much of this we've already gone over. The injured patient is hyperglycemic. Insulin levels during this time are elevated, but insulin is not effective early on in an injured patient because there's a state of relative insulin resistance, presumably due to downregulation of insulin receptors. Hepatic glucose production is increased by up to 100%, and this is under the influence of cortisol and glucagon. In the injured patient in particular, glucose production occurs at the expense of protein, particularly alanine and glutamine. It might make sense to try to intervene in this protein breakdown response by giving the patient glucose. So if you give your injured patient a glucose drip, does it have any effect on protein breakdown? And the answer is no. Normally, if you gave a patient glucose, glucagon and cortisol would be decreased. But in an injured patient, those feedback mechanisms aren't happening. Cortisol and glucagon are under the influence of many other things besides glucose. And so, unfortunately, we're not able to reverse this catabolism by just giving a nutrient such as glucose. Protein metabolism is characterized by protein breakdown, which you could, if you were so inclined, you could measure by measuring nitrogen excretion in the urine. This is really a period of autocannibalism. A patient is digesting their protein stores. Initially, this is skeletal muscle, but as time goes on, visceral muscle becomes involved as well. Besides using these amino acids for gluconeogenesis, they're also used to synthesize a variety of important healing products like acute phase reactants and coagulation factors. Glutamine is also an energy source. Colon cells use glutamine, as do lymphocytes and fibroblasts, which will become important in healing. Again, all of this protein catabolism is under the influence of cortisol excess and a variety of cytokines that are important in the inflammatory response. And in the same way that giving an injured patient glucose doesn't reverse this, nor does giving them protein reverse this, or at least not to any meaningful degree. Protein catabolism occurs because the hormonal environment says that it has to happen, and normal feedback mechanisms are interrupted during this injury phase. The only way you get out of this catabolic phase is you have to deal with the injuries. And so the burn patient, their wounds have to be covered completely. A septic patient needs their source of sepsis drained. A trauma patient needs their pelvic fracture stabilized, or their femur fracture rodded, or their open abdomen ultimately needs to be closed. Once these events happen, then the patient can start to enter the anabolic phase, and all this catabolism, which is so dangerous, can end. An injured patient is highly dependent on free fatty acids as an energy source. Skeletal muscle and heart use these critically. The injured patient does not use ketones very well, and their ability to use them is inversely proportional to the severity of their injury. This is a very fundamental difference in the starving patient, who ultimately can use ketones very efficiently and preserve proteins to a reasonable degree. All right, I'm going to end this topic here. We will go on to talk about surgical nutrition next. And for those of you who prefer to see this material in a written form, this website should cover everything we talked about today. Thanks for your attention. We'll talk soon.